and welcome to the Health GoLIVE Webinar series. Today's episode is brought to you by your friends at Medallion. We would like to remind you that the Q&A feature is available, so feel free to send in your questions for speakers throughout the discussion. And with that, I will turn it over to our moderator who joins us from Medallion, Derek Lowe.
Wonderful, thank you. And thank you to those in the audience for joining us today. And thank you to our panelists for joining as well. I'm really excited for today's panel and looking forward to our conversation. To our audience, we welcome questions throughout the panel. We'll try to address them throughout the conversation, but if we don't get to them, we'll save some time at the end for our panelists to answer. So first, I'd love to kick off today with a round of introductions. So to our panelists, if each of you could start with who you are, what you do, and most importantly, what motivates you to do what you do. So Lisa, if you could kick us off, that would be wonderful. Then we'll have Jenny and Hiem.
Sure. Thanks so much, Derek. Good afternoon or good morning, depending on where you are in the country today. I'm Lisa Fry, and I'm the president of Value-Based Care for SCP Health. SCP Health is a physician-led healthcare solutions company that employs over 8,000 clinicians across the country. We started in emergency medicine practice management 50 years ago, and we now focus on clinical care and patient engagement across the continuum. I personally have responsibility for our post-acute care services, including telehealth care in the home and patient engagement, and our value-based partnerships with health plans and other risk-bearing entities. And the reason I do what I do is that I love, number one, to help clients solve complex issues. And I think we've got a tremendous opportunity to try to improve healthcare, both from a cost and experience perspective, by really helping to streamline and simplify the system from a patient's perspective, help them navigate a very confusing, complex, fragmented healthcare system more effectively so that everybody's experience improves. So thanks very much. And I'll turn it over to, I think, Jenny.
Thank you, Lisa. And thank you, Derek, for the opportunity to be in conversation today. I'm Jennifer Schneider, and I am the Chief Executive Officer of Homeward Health. Homeward Health is re-architecting the care and delivery of health in rural America. And we're doing that in partnership with existing providers and other people within the rural ecosystem. So what that means is we enter a market and we provide care to Medicare eligible individuals and do that in partnership with payers so that we own the total cost of care and are responsible for the clinical outcomes. I'm motivated to do this. My background and training is I grew up in rural Minnesota. I was diagnosed with type 1 diabetes when I was 12 and was in and out of DKA before being able to see an endocrinologist for nearly a month, which I thought was normal because I had no other frame of reference until I went to Hopkins for medical school and started to understand that access to specialty care in rural parts of America is really difficult and often very necessary. We know that 1 out of 5 people, or 20% of all Americans, live in rural healthcare, live in a market that's designated as rural, and therefore get healthcare in those markets. And we also know that the mortality rates for people living in rural areas is 23% higher. And so this is a combination, a love of difficult problems, a passion to do something that's very meaningful to myself and to my family, and a great team to tackle this. So delighted to get to be here in conversation.
I guess I go next. I'm really humbled by my colleagues that are on this panel. And Derek, thank you for the invite. So my name is Hiem Nadal, and my current role is the director for the Center of Innovation in Care Delivery. And so prior to that, however, I had the greatest opportunity to really open up an OB unit from scratch. And that was my startup, as I say, and learned so much on how we can actually design a practice that's with the patients in the center as well as our staff. And so we've had many successes with that. And so out of that passion and learnings, I now run a center where we actually go to patients and go to the front lines and say, look, tell us what your pain points are and what are your ideas for your solutions. And my background with my MBA is on innovation and entrepreneurship. And so what we do there is take that idea and build it out to prototyping, implementation, whatever that solution might be.
Amazing. Well, thank you all for sharing your stories. Incredibly impressive.
So sorry.
No worries. As a quick intro myself, I'm Derek Lowe, the CEO and founder of Medallion. My journey into healthcare looks, I think, quite a bit different from all of yours. But it started with a conversation with a friend of mine who runs a company called Row. His name is Zach Raitano, a few years ago. And it started out of really me asking him what pain points he'd experienced scaling up Row. He basically talked about how convoluted and painful cross-state licensing is. And fast forwarding to the present, we've created a suite of products that help healthcare companies of all sizes efficiently manage their provider networks. But that's enough about me and Medallion. I'd love for us to just dive right in. So starting at the center of it all, patients, how have each of you seen healthcare evolve to be more consumer or patient driven? Jenny, would love to start with you, then we can move to Lisa, then PM.
Great question. I think about consumer driven and healthcare relative to other industries. And so I like to give the example around travel industry. I'm 47. I actually remember going into a travel agent office to buy a ticket. You'd have to go. They were the only people who had access to the information. You'd spend a lot of time. You'd look at some really fun magazines while you were there, but you were at the, kind of the mercy of the person with whom you were working. And all of a sudden there came in a day where we said, we think Americans and people in the world are smart enough to be able to do this themselves and probably want to have the convenience. We flipped the computer around and we gave it to people. And lo and behold, we could do it. We could schedule our own flights. We were able to do that. And so we've seen consumerism, which in my mind means just ease of access and design principles to serve end users in many other industries. We've seen it in banking, we've seen it in travel, we've seen it certainly in entertainment. And healthcare is still, I think, kind of one of the last frontiers to do that. But what we've seen is a bigger focus on what people actually care about, what people want to experience in their healthcare journey. And that can be ease of scheduling, it can be interesting different payments, it can be, the site of location. But we've seen that develop, and that feels right to all of us because we don't think of ourselves as healthcare consumers versus travel consumers versus produce consumers. We just think of ourselves as people. And so while we're experiencing all these other conveniences in our other aspects of our life, day-to-day existence, shopping, commerce, we should also be having that. And so you're seeing very similar principles being applied in healthcare.
It's a great point, Jennifer. I agree. I think I would have said a lot of those same sorts of things. I think that convenient access to care is an important part of being, a patient-centric system. And you're right. I think patients define that differently for themselves. What that word convenient means. I think the access part also has to do with the affordability of it and really the transparency around pricing. That's really going to be, I think, increasingly important in the future. I think that's one of the places where we still have some catching up to do, for sure, with other industries. And I guess the only other thing I would add is really just for me, the thought around being more sort of patient driven also has to do with making the data about their care and their health status in general accessible to them as patients as well, instead of this medical record being this secret thing that only the physician gets to see. So I would just add that, but that's great definition, I think, so far.
Yeah, it's all great points and stuff. And I think just to bring back to my roots of innovation, what we do a lot is what's called human-centered design and design thinking. So, okay, that's a fancy word, but what does it really mean? And what it means is that who are we devising the solution for? Who is healthcare for? And looking at it from that perspective, from those patients. So I think it's wonderful that we're hearing from these patients and what they need and what they want for both ourselves and as well as the patients themselves. And the other thing that I think is growing within the health systems and out is our patient and family advisory boards. I think they're a wealth of information. I'm always at their meetings and, hey, what do you think about this? Is this an accurate assumption I'm making? And they're just so happy to give you their point of view. And so I think it's good.
Yeah, fantastic. I especially like Jenny's point around the fact that we don't really think about travel consumers or banking consumers. We just think about us as consumers in general. And so I think that makes a lot of sense, and is a good lead into my next question, which is, with all of that in mind, do you think healthcare becoming more patient driven is a good thing? Hia, maybe you can take this one first, and then we move to Jenny and then Lisa.
Yeah, I think a lot about this, and I think basically it's really quite good. I think when we can partner with the patient, I think it's a win-win with everyone and trying to understand everything from their perspective. But I also think it taught us in the health system to really pause and really consider things that we're doing and challenge a little bit of the status quo. And I can give you a very simple example, which is we know sleep is very important for healing. And yet we're going in there every 2 hours or 3 hours and bothering the patients, waking them up. And so it allowed us to sit back and say, do we really need to be doing all of this? And if so, is there a way to cluster so we maximize the amount of sleep that the patient gets? So I think all of that is really good. I am challenged, however, I have to say, with things like when we're doing patient satisfaction surveys and the wait time, have you seen your provider within 15 minutes? And I think what you do by giving that amount of time is really setting an unrealistic expectation sometimes, because the patient in front of you might have a bad diagnosis, so you need to spend more time. So that 15 minutes isn't always a standard that we can meet. And then the other example is immediate access to lab results. And sometimes what happens is, so if I saw 40 patients, 20 of them had labs drawn and they have immediate access to those results. Sometimes they don't understand the results, they become anxious, they tap into Dr. Google, and they become more anxious. And now there's an additional 20 calls to the practice. And so I have 40 patients ahead trying to get through the calls. Some are emergent. I don't get back to the patient till either later that evening. And it already sets up sort of a bad relationship, right? They're angry, they're anxious. So sometimes we just have to be mindful of those things. I don't have all the answers, but maybe more education or context around these labs, et cetera, and all the things that they can look at.
I'll just add in, so the question was, do we think that patient-centeredness or patient empowerment is a good thing? And the answer for me is a fundamentally yes. And I think the question's almost moot because it's already here. So I don't think you can go backwards. But I want to maybe even go a step further, which is, I think one of the failures in healthcare is hierarchy in general and in us versus them. Like, I'm the doctor, I went to medical school, I know this, therefore I will tell you what to do and you will go do it. That model doesn't work in parenting, doesn't work in business, certainly doesn't work in healthcare. And so, in the companies where I've been involved, we don't even call people patients, we call them members. They're simply people. We're all people and we all have health needs. And so I think this dichotomy of us versus them is fraught with a whole bunch of problems. We know that 80 to 90% of all healthcare costs are related to chronic conditions. And we know that management of chronic conditions is a day-to-day, minute-by-minute decisions that you're making, and it has nothing to do with your healthcare provider, zero, zip, nada. And so we're trying to motivate and understand people to better manage their own health when they want to. Again, that's a choice. They don't have to if they don't want to. And so again, I think having people have a seat at the table is the only path forward. And frankly, really delighted that we're in this position where it's no longer an option.
Yeah, I absolutely agree. I think at the at its core, having patients be more informed and more engaged really does drive better outcomes, and it makes them better partners, and so that we can make those personalized decisions. So I absolutely agree. And then the only other thing I would add is I agree with him. I think there is such a thing though as too much of a good thing when it comes to the consumer being really engaged in their health, and I think patient sat is a great example of that. We started out with the triple aim, and I think that that sometimes the relentless focus on patient satisfaction scores and the way they're measured currently creates unintended consequences and behaviors that really don't help anybody in the system. So I think in general, absolutely yes to the question, but you've got to be careful about how you apply it as well.
Yeah, I think those are really interesting points, and especially here, I don't think that most people would really think about that. And so that's really fascinating. I think transitioning a little bit to more on the provider side, there's been some talk in various forums and communities and even conferences on the somewhat negative impact that patient-driven care is actually having on providers. So as leaders of your respective organizations, how do you think we can help to remedy this for the providers who've dedicated their careers to helping those who really need care the most? Pia, maybe you can also take this one first, and then we go to Lisa and Jenny.
Yeah, sure. So I just want to back up a little bit, I think, because I had this experience with my staff who, we delivered 4,000 babies a year, and they would say, oh my God, it's so busy. It's so busy. This is ridiculous. And I'm like, well, but wait, we're still delivering 4,000 babies. What is happening here? And so I decided to write down everything that they had to do for patients. Okay. And what it ended up doing, I put it on a paper and it scrolled out to 6 feet. So there's this never-ending mandates and guidelines that we have to do for patients, which are, if separately, are all wonderful. We should be doing all of them. But in aggregate, you just don't have all the time that you need to do that. So that's number one. And then layering on top of that some of the unrealistic expectations and from patients, and I'm not sure it's an unrealistic expectation. It's just what they've come to believe the way things should be. And so I think it was Jennifer that said this. It's a partnership, and if we do it correctly as partners together, then we can begin to solve a lot of these problems that the physicians are feeling. I was on the elevator with a primary care physician, and I said, I just read a medical economics paper that said your documentation takes an additional 3 hours. And he had this whole pile of paper with him as he was going home. He said, oh, I think it's more like 5 or 6. They go home, they give their kids a bath, they have dinner with their families, and then they're back up again documenting. So, we really need to have everyone at the table, the payers, the policymakers, and I know that's probably unrealistic, the patients, the clinicians, and really talk through what is going on, that this is unsustainable, and how can we begin to sort of get rid of what we call the stupid stuff or things that don't make sense, and help both the patients and the providers.
Yep, I agree. I think it's a great point, and I kind of think about it from the perspective of the impact on the clinicians. And one thing that's incredibly important just for motivating human beings in general is the level of autonomy or control they feel over what they get to spend their time doing, and so I think that to the extent that you can reduce some of that noise and add some autonomy back into a clinician's life, then how they proceed through their journey and through their day really will help to then, I look at it as sort of all boats rise with the tide. If you have a happy clinician on one end of that engagement and a happy patient on the other end, both of them are going to have a much better experience. So I think that, really addressing, I'm thrilled to see that now everybody's focused on the quadruple aim versus the triple aim, because we had definitely left the clinicians out of that first model. So totally agree. Jennifer?
Yeah, I don't have much more to add other than, I do think at the end of the day, those of us who have trained, like you go to training, you're chosen to go into practice because you're empathetic, because you're interested in a whole bunch of different things. And then we funnel you in and tell you to do one small thing that you spent years of training and hundreds of thousands of dollars that is maybe not what you needed to get trained to do. And so I think I really agree with what Lisa's saying around autonomy, but I also think it's recognizing the skill sets that people are bringing and allowing people to use their specific skill set. That's where all of us find joy in our work life. And so there's this world that like all clinicians must do X, Y, or Z. It's probably not right. And, or, there's the technology seen as a burden rather than an enabler. And so there's a world in which I think working in both of those angles really allows for more desirable outcomes for working for clinicians.
Yeah, and then I guess following on to that, what what are your specific organizations doing to to impact this, if anything? Maybe yeah, I can start with you.
I'll start actually, if that's okay. So at Homeward, we have a different model, right? So we are not a fee for service. We are a total capitation. And so what that allows us to do is deeply understand what our members need and then deploy the types of healthcare that they require. So we're servicing people in rural markets. So we start with a home visit. We really get to understand what someone's life is like. We then deploy a fair number of technology-enabled services because we're in rural distributed markets. It's impractical for them to come to us or for us to go to them on a regular basis. So things such as, heart rates and blood glucose and scales. And then we reach out to them based off of what needs they have. From our clinician standpoint, our clinicians, one, are incredibly happy because they feel like they're doing the work that matters versus kind of doing the billing every 15 minutes, getting somebody else in the door. So it's a change in mentality, I think, moving to total capitation. The other thing that I've been really surprised with is, we deploy a lot of, we have this principle around allowing people to work at the top of their licensure. I have a handful of nurse practitioners who have very vocally said they've never been able to do what they've been trained to do because in other systems, they've been told that that's the doctor's job. And it's super rewarding for them to actually come in and do the things that they've been trained to do. So I don't think as a writ large, industry, we're really allowing people or asking people to practice at the top of their licensure. And there's an incredible amount of joy that comes with doing that. And I think the third from us is, again, we're doing an innovative care delivery model. We're doing something that's new to people that haven't received this and allowing clinicians to be part of the solution. They joke all the time, like, I've never been in a place where the leadership's actually spent any time with us. Like, why are you still asking us questions? Like, well, because you're the front line and you understand people and you are going to help us evolve this. And so I think that we've gotten to this, like a little bit of like, this is your job, go do it. This is your job. This is what's required. And without allowing and the ability to kind of bring some of that back, the learning back into the ecosystem.
Terrific.
Hiem, maybe do you have anything to add there?
Yeah, I love what Jennifer is saying, and we're trying to do the same and really focus on. We're at a big, large tertiary care academic center, so we're seeing the sick of, really sick patients. But what we're started to do is, let's not take care of you when you're sick, but really focus on your health as well and health maintenance. Take care of you at home. What other models can we look at to really move that continuum? So I think a lot of that. And the only other thing that I think I would add is that because we're having such issues with staffing and things like, they're heavily involved in creating these committees or these functions where they're really focusing on the well-being and not just mental well-being, but really, I always say this, getting rid of stupid stuff, or really working towards getting rid of the stuff that doesn't matter anymore, as well as recruiting and retaining our staff. And there goes a bunch of stuff that goes underneath there to be able to do that. And I agree. I think that as we do this more and more, the providers are much happier, and so are the patients.
Mm-hmm. Yeah, so I think at SCP Health, we come at it from a little bit just different perspective because our roots are in hospital-based services. So, in terms of emergency medicine, hospital medicine in particular. And so a lot of times we do have folks that practice at the top of their license. And I do think that one of the things that we've seen, especially over the past couple of years, but even before the pandemic, is pushing, pushing folks to just completely eliminate all the excess latent capacity in the system. So we're constantly piling more top of license sort of work on people. And I think what we're recognizing is people need some variety. So clinicians and providers need an opportunity to not just work 7 on, 7 off all the time, and that's the only thing they do. So we're really looking at creating opportunities for them to spend some time out of every month doing telehealth visits that might be much more minor acute care types of needs, following up with their patients after they've left the acute environment, really getting a balance of work environments so that they have, again, that sort of autonomy and a little bit more control over what their work environment looks like. It will, ultimately that takes a little bit bigger workforce to accomplish than all the things that we're trying to accomplish. But I think that giving people some opportunity is one of the things that will help us with sort of long-term retention and reducing that burnout.
It's wonderful. Hopefully there are folks in the audience that are also managing networks that are taking some notes here.
Yeah.
Transitioning a bit, when it comes to the provider networks that each of your organizations manage, what are some of just generally the positive trends as well as challenges that you're seeing right now? We've talked about a few, but we'd love to dig into that a little bit more. If you could kick us off, then we move to Jenny and Yam.
Sure. I thought of a little bit about that. So I feel like to a certain extent, we all have to dig pretty deep these days to find some positive trends. A lot of it feels sort of negative, but I do think that I just mentioned, more flexibility in work opportunities because of the fact that we have opened up additional access channels for patients does help for, for the clinicians as well. So I think that it gives people also an opportunity to master new skills, get a little exposed to different things. So I think that's a positive trend. I think obviously the big challenges are the workload, the lack of support across the care teams. Maybe if you're, even you've got an adequate coverage of clinicians, then you have a shortage in some other area of the hospital, there's support staff or whatever. And then I think depending on the person's personality, to me the splitter between sort of the positive trends and the challenges are possibly these constant adjustments that we're all dealing with these days. It's just the next new thing a week from now, it'll be different. And some people thrive on that variety, and some people, really have a struggle sort of dealing with that constant evolution and the speed at which it's happening these days, especially in healthcare. So I think those are some of the things that we're seeing. We're helping people try to deal with.
Yeah, I would just echo that. I think there's new and different approaches to delivering healthcare, and there's still older traditional ways. And so depending on who you are, there's opportunities to go to where you gravitate. And so I think that we're seeing that and feeling that real time. I think it's exactly what Lisa was describing with even within our organization. So there's opportunities in both ways there.
Yeah, and the only other thing I would add is I think we're seeing, patients want to be seen within their communities and closer to home. And I think that we're, trying to do that and sending our providers. That could be both a positive and, sort of a negative for those providers running around to all these places. But I think they love that variety as well. And yeah, I think there's going to be more and more of that. But I think it's a positive trend.
And then I guess when it comes to, I guess how you are or would navigate some of these challenges, any advice or tactics that you could share with those who are listening in? Lisa, maybe we start with you and move to Jenny.
I think for us, it's just continuing to up our game in terms of communication and visibility about those trends and challenges. I think that it's a lot harder to deal with those if you're a clinician, your head's down every day, you're seeing patients, you're busy, and then all of a sudden some market trend comes and, kind of whacks us upside the head as a practice and as a team and a group, and you don't see it coming, then I think that's a big challenge. So what we try to do is, and obviously I'm not a clinician, I'm a business person, but so I look at a big part of my role as trying to stay ahead of what's happening in the environment, so we can constantly be communicating that to our clinical teams, so that they don't feel like they're getting just buffeted by these tidal waves sweeping over their heads sometimes. So I think communications and visibility for us is a big one.
Same for us. So I think metrics, having dashboards with metrics that we huddle on a daily basis, so that there's a touch point around a like clearly articulated group goal across the population, how well we're doing, goes a long way. Again, I think communication, articulation, measurement, and transparency make all of us feel more comfortable and are good reminders as to what we've done well, and frankly, what we as a group or collective group have not done well.
Right. And and the only other thing I would add is that we have the right people at the table to develop those metrics and what we're looking for. And then the next step is, what do we do about them when we need to improve, and keeping in mind all the unintended consequences.
Wonderful. Transitioning now again slightly, you're fast forwarding a few years from now. What do you think the future holds for your own provider networks, or just the broader provider community as a whole? I know it's a general and wide question, but yeah, maybe we can start with you, then move to Lisa and Jenny.
Sure. I do have to say, I was recently on the other side. My brother had open heart surgery, received exquisite care. But while in the intensive care unit, suddenly I was overwhelmed with the minute-to-minute care that he needed. And I can tell the staff was very overwhelmed and short-staffed, and having to go between, 2 or 3 patients. And I had this, we're hearing about all the staffing shortages, and we can't retain staff. They leave within 2 years. And I really honestly believe, and this is my opinion, that we're really at a crisis point, and I think we need to pay attention to that. So I really worry about who is going to be taking care of us in the future. But on the flip side, I do love the idea that we're looking at different settings, we're looking at different models, we're looking at, I so believe in having everyone function to the top of their license. Not only the advanced practitioners like the nurse practitioners, but nurses can do so much more in this team-based, sort of going back to that team-based care, looking at everything that needs to be done for a patient and backing into who's the most appropriate to do that. It doesn't have to all fall on the provider, as an example. So that's what I'm sort of excited about, to see what's really going to come out.
I think from my perspective, it's similar, but with maybe a little bit different angle, but just really thinking about how we apply more technology to help clinicians' lives and jobs be easier. And, I think to a certain extent right now, people are looking for that right balance, right? That infamous work-life balance. But to the extent that we can introduce tools that reduce friction, like even the credentialing tools, Derek, is a great example. You introduce tools that reduce that friction of the paperwork and things like that for a clinician, and then you give them a tool that can really segregate, this is my work life tool and this is my personal life tool. So I think doctors sometimes have, they've got their phone and people are texting them, and if you let that commingle too much, I think that is something that people might be looking to just pull apart a little bit and make things a little cleaner. So I think that's one of the things that we could do.
Yeah, and Lisa, I love that with the technology, because that is accurate. And I just want to add that, again, really involving the clinicians and the right people to actually develop those tools.
Mm-hmm.
Most of the time they get developed for us without input and without,
right.
But if we co-develop these things, that really makes sense for the frontline clinicians.
Mm-hmm.
I think I'll have comment in the question, but then respond to what Hiam and Lisa were just saying. I think that healthcare is going to look really different. And I think we're at the beginning of that. And I think most healthcare will be delivered in convenient settings for those of us who are healthcare consumers, which is all of us. I think that providers, and I think much more will be done through technology enablement of services. I think providers will continue to manage most high acute crisis intervention procedures. That type of skill set and training will continue because it has to continue. But many more things will be done in a way that feels very personable, but doesn't require a person, if you will. And the reason I say that is because we have a service crunch right now, and I don't think that's going to go away. And do not let this crisis go to waste, right? Like all crises, it's, ignite and excite new opportunities. And so I think you're going to see a wave of opportunities. I think I view kind of work-life balance very differently, which is we have what, like, just kind of how we're not a patient or a consumer, we're just a person. We have one life. And I think frustrations for work are almost never the frustrations because it's too much, when it's because you feel like the work you're doing doesn't have value, versus like the quantity of work. And so if we get to a place where we can allow our clinicians in particular to do the work that they're trained to do, that they went into the profession to do, but not the work that kind of comes along as part of the dirty package, and minimize that, I think that the enjoyment and sustainability of being a practicing clinician will increase, right? And so I think it's not around quantity of work as much as it is and the exact amounts of pieces that we're asking people to do. And I think we as an ecosystem will have to sort that out, or, I agree with him, like, otherwise we are in a crisis. So like we will have to figure it out, or we'll break, right? And so like, I see, again, technology, and I agree with the comment that we have to involve people for whom technology is being developed, right? So electronic health records, great. I'm not sure there was a bunch of physicians sitting around, like deciding like exactly how they wanted that to look. There are some, right? But my point is, like, we need to be very thoughtful on user design, and leveraging technology to allow us to get to where we need to be.
Yeah, excuse me. Sorry, I've got a bit of a cold. First of all, just to be clear, we didn't give Lisa any bribes for plugging the line.
No.
Thanks for that. There's a question from the audience, from Michelle, that I think actually relates directly to what we just discussed here, which is, what technologies are you currently seeing that are relieving some of the administrative burden added to providers based on direct care versus regulations? And then do you have a vision for what other technologies could be helpful in meeting this quadruple aim? Maybe
Go first, Jennifer?
yeah, Lisa,
Yeah.
we could start with you then.
Oh, okay. I can give one example. We've built a set of applications for our clinicians that they have on their phones, and have that available. So there's a couple of different pieces to it. One is truly just a HIPAA compliant communications tool. So it allows us to broadcast messages to our clinical teams, but only to the people that need to hear it. And again, it gives them a little bit of separation because it's not in the noise of their regular email and their texting. The other thing, I guess I would say for us as an example of a technology improvement is truly reducing that friction of credentialing, that entire credentialing and re-credentialing and enrollment process. It takes a ridiculous amount of paperwork to pull that all together. And again, we've created an app called Practice, where we allow, we administer and sort of keep track of all of the different pieces of information that we need from a particular clinician to put them through the credentialing process, and so it literally looks like a pizza tracker. They can kind of see where they stand, in which documents are completed and totally fine, which ones they can upload it all through the app right off their phone. And so it just is one of those things that is so painful when you're trying to onboard a new clinician that just doesn't need to be, in the future. So it's just one example that we have.
Those are great examples. And I think that, Michelle, I think the question is a great one, which is, again, technology solutions really that are optimal map out the pain points. And so if you think about the administrative pain points for clinicians' lives, I agree with Lisa, and another head nod to Medallion, but like credentialing is a big one, and keeping that up to speed. I mean, that is a problem. I think coding is something that's really difficult for individuals. It takes up a lot of time. It's hard to see the value in that often. I think scheduling follow-ups. I think, following up on labs and interpreting the endless amounts of data that are coming in from tracking devices for individuals. And all those four, there are examples of technology in each of those categories that have made those much better and continue to make that much better. So I think the world of technology investments has done a beautiful job of starting to understand what the pain points are, and now is bringing products to market that are increasingly better to really eliminate those pain points for providers.
Yeah, and I'll add another one that's very painful is prior authorizations. So I think some of them take days, and we have to question about why that happens. But some technology to help with that and pull the data, the clinical data that's needed, and then sending it out to the appropriate payers. The other thing we just did, we implemented technology for a general medicine floor that's really quite busy. And so we followed the nursing staff, and they're all running around, and alarms going off, and things are beeping, the bed is beeping, the monitors, etc. And sometimes they just don't have enough time to get to the patient. And so with this technology, which has the sort of the eye on the room, the hospital room, and really giving you some feedback of what's happening within the room, de-identified data comes out as a stick figure as a patient. Are they getting out of the bed? I've been so busy, let me just look, and there's live views right into the room to really, help with their efficiency. And what we found, we haven't completed the 6-month pilot yet, but we found the immense, checking in on patients has really increased. Spending more time with patients has really increased, because it's better decision-making and smarter ways to get to the patient. So, these kind of things, just following staff during their day and really trying to focus on what's most painful for them.
Fantastic. And then, actually following on to what you just said in terms of, how to get to the patient, transitioning back now again, just for a moment to, patient-driven care. What do you think the future holds for patient-driven care, and how do you think it's going to be different than what's happening today? Lisa, maybe if you could take this one first.
Sure.
Yeah.
Well, I absolutely agree with what Jennifer said just a little bit ago. I mean, more home-based services, really delivering care in environments where patients are much more comfortable. It's more convenient for them. I also, though, hope that the other big one, from my perspective, is that there does seem to be a continued push in the healthcare environment in general for value-based payment mechanisms. And again, I mean, Jennifer, with Homeward, on a fully capitated model, you've got a lot of opportunity to reduce the fragmentation of the healthcare system that exists because of all these silly handoffs that are created by fee-for-service medicine, and so I really hope that that what the future holds is, as we go to more and more sort of risk-bearing models and value-based models, that it will reduce the fragmentation and eliminate those barriers to doing that, because there certainly have been a lot of barriers in the past at that, and that we deliver care in the places people want to be.
I would just echo what Lisa said, with one addition, which I think that people are going to be part of the value-based care solution delivery. Today, it's providers that do the contracting and are financially. I think there'll be greater involvement, I hope, and greater partnership with the people who are receiving the care. Again, that's just great to align economic incentives and behavioral incentives in a world where there's absolute choice, but there's a commitment or an understanding of what those choices mean and what the outcomes mean. So I think that's an evolution in value-based care that we haven't seen yet, or don't talk about, with the people being the patients, or the people whom are receiving the care being a part of that economic piece of the puzzle.
Yeah, I totally agree. I really don't have anything else to say. They've said it beautifully.
Fantastic. Cool. Well, I think we'd love to transition at this point to audience Q&A when we still have a bit of time left. So I'll read out a couple of these here. One from Igor is: the current healthcare system is designed to reward everyone in the system when people use healthcare more. The best policy would work to keep people out as much as possible. In what ways do your organizations work towards implementing practices, products, and services that keep people healthy and are of sick care system? What barriers do you see to doing more? Yeah, maybe we could start with you.
Geez, I think just what Lisa and Jennifer just mentioned, the value-based care is constantly now being talked about. And I agree that I don't think we've really tapped into all of that, and keeping people out of the hospital, focusing on their health management rather than waiting for them to get sick. We see that, the emergency rooms are really just overwhelmed with people coming in. I think we have to focus a lot on behavioral health. Many of the patients that end up in the emergency room, because they're there weekly, every few days, because we don't have enough behavioral health providers. Looking to our payers to really help with that, and across state lines and licenses and stuff like that. So I think rather than be focusing on where you are, but really how do we tap into the broader ecosystem? And that's how I think we'll keep people healthy.
It's Lisa. I can go next because I have a feeling Jennifer's going to knock this out of the park. So I want to go before
Yeah, I
her.
think so too. I was thinking she should have gone first.
Yeah, exactly. Then we could just say done. Now, in terms of our organization specifically, I mean, one way that we try to do that is that obviously when someone's in the emergency department, it's usually a teachable moment. So we do follow up with our patients within 24 to 48 hours of their visit, because we feel like we've actually done a lot of analysis, and more than 50% of our patients who if they're going to bounce back, because after an initial visit, they bounce back within 7 to 10 days. And it's typically because there's a gap that they can't get to their PCP and follow up for care. And so we try to get to them and help them navigate that gap so that they don't have to bounce back and use the ED as their only option, and really try to help them move on in their care journey and then their healthcare journey. So that's just one example of what we do, but I feel like Jennifer's job is all about this. So
Well, I was going to actually maybe start by telling a little bit of a story. So General Catalyst, which is one of the founding investors of Homeward, their thesis around companies is called health assurance. Like, wouldn't it be great to be assured that you could get good health outcomes? And a large part of that is preventive. And then the quote, and I don't remember whose quote it is, but it's really hard to get somebody to do a job when their paycheck depends on them not doing it. Right. And so one of the big reasons why healthcare, I think, is so broken is economic incentives are not aligned. And so, if you get paid more when people come back sicker, what is the incentive to actually make them better? I mean, there's a altruism, but think of a world in which you bought a car and the price you paid for the car included 10 years of the mechanical repairs that you're going to need to do. And that those mechanics were, being paid by the car production company. So they actually were aligned, rather than the car mechanic that tweaks something. I don't know if this happens to you, but every time my car gets tweaked, I come back a couple of weeks later to untweak or retweak, right? And so there's not an alignment of economic incentives. So this idea around taking total capitation, we have to do that in rural markets because we have to deploy care models that are not reimbursed through a fee-for-service world in order to deliver the care that's needed. But what it does do is it puts everybody in the same team. We're all swimming in the same direction. And so we're all working toward better clinical outcomes and total cost of care. And again, economic alignment in healthcare is broadly missing. And I think it's really hard to invest in the things you need to invest unless you have economic alignment.
You're right, Lisa. She knocked it out of the park.
I know. Definitely agree what she said. Yeah.
Awesome. Next question is from Elizabeth. How do your organizations think about the role of the healthcare system in achieving healthcare outcomes versus the role of the patient? And how do you see the evolution of specialized solutions and helping people navigate to the right service versus a one-size-fits-all approach? Maybe we can start with Jenny.
I think this is a really great question. I think, this touches a little bit on who's responsible for healthcare outcomes. And I think you've heard all of us talk about the goal or desire around patient-centered design is to have people as partners in that. Like, it's not the clinician's job solely to make somebody do something that can't possibly be the job. There's a joint responsibility. I think that understanding, again, this idea around, I'm a primary care doctor, and I used to think my job was to tell people what they needed to do to hit the clinical guidelines and then give them the right meds. And like, pretty much that never worked. Instead, I realized over time, my job was to actually understand each person as they walked in and what motivated them, and get them to do what I wanted them to do through what motivated them. I'll give you an example. Somebody with diabetes, type 2 diabetes, has a high LDL and is slightly overweight. And so I said, well, your LDL has to be less than 100 per the clinical guidelines, and your BMI should be, below, drop 2 BMI points. Rarely did that like achieve an outcome, right? But instead, if I said, oh, you know what, you told me about your dog and your partner, what a great idea would be for your partner and you to take your dog for a walk after dinner, and like think about that time you could have together. And all of a sudden they start exercising, not to hit the LDL goal, not to lose weight, but to do what they care about and get that secondary benefit. And so again, I think that this line around what the health system is responsible for and what the individual is responsible for is tricky, but it has to be a joint responsibility. And I think the system with the knowledge bears the responsibility around motivation and pointing and directing and coaching, but has to also get the individual person has to buy in, or it doesn't work.
I agree. I don't have anything to add to that. I totally agree. I think that's right.
Yeah, and I want to ask Jennifer, I think as a primary care physician, we need to help educate them with that, because they're the ones that have the greatest touch point with the patients. I know, in my opinion anyway, and really helping our primary care physicians who probably are suffering the most, to be honest. Yeah, so and I love that. I love the way you said that, and really think about what really matters to patients, and that's how we come at it.
Another question here from the audience is, the industry has been talking about switching from fee-for-service to value-based care for more than a decade. Some organizations have already started the transition. When should we anticipate more jumping on board? Hia, maybe we can start with you.
I think I'm going to defer, because I think that we're still struggling with value-based care and really what does it mean and how we're going to implement it. I'd love to hear from my colleagues how they're doing it, because that's one part that, I'm still a little bit unsure of.
Sure. I'll take a stab at it. And unfortunately, I've been in healthcare 30 years now, and it's been that way the whole time. So it's definitely more than a decade for sure. And everybody, like every 5 or 10 years, people are like, this is it. This is the tipping point. It's finally here. But it'll be interesting, and I'd be curious to hear others' point of view on this. I honestly think that perhaps this time the system is so broken that we have no choice but to move forward now. I think that margins, I mean, from a financial perspective, healthcare to a certain extent is a business. A lot of people say, no margin, no mission. And so you've got to make the economics work. And I think that given how thin we've been running for so long, and then when you see a major disruption like a 10% increase in labor costs all of a sudden in a very short period of time, it really is going to force people to think creatively, much more dramatically than you can't make incremental change anymore. It's not going to be enough, so I'm actually sort of bullish on the fact that maybe this time really kind of there is something different about it, and you can't get away with just an incremental change anymore.
Nothing to add. Totally agree.
Awesome. Another one here. What are your organizations doing to combat workforce challenges, i.e. staff shortages, speed of credentialing, privileges, clinician burdens, etc.? Lisa, start with you.
Oh, sure, I can take that. So I talked a little bit about some of those earlier, but I think that for us, it's really trying to take the the non-clinical friction out of the system, the administrative work, try to reduce that burden, design those tools so that they are, clinician driven tools that are useful for folks, really understand what those are. But staffing shortages is definitely a challenge. So I think that getting more creative about how to apply our clinical resources, so it used to be in our business, it was sort of like you worked a 12-hour shift and that was it, and then I was like, woo, it was a big disruption to only work an 8-hour instead of a 12, or something. I mean, and so nowadays it's really trying to figure out how do we help people fit any sort of availability into their schedules, because we need to really use all those fragments of time and make it easier for folks. And I think maybe it was him earlier, you talked about even nurses practicing at the top of their license. I think then that what that means is we've got to backfill the busy work that that you don't have to be a licensed nurse to do, with another appropriate resource. I think sort of, kind of pushing everybody up and backfilling sort of on those more administrative tasks are important.
Yes, and in addition to that, everything we're trying to do the same. In addition to that, so one is nursing, and what we're trying to do. We've just brought on, a few hundred new graduates, but the difference this time is to really put them through what's called nurse residency and precepting them and mentoring them for 2 years out. And so that they always have, because we heard from them, and it's very scary as a new grad to just get out on the floor and practice without that additional mentorship and stuff. And then they're also studying, a lot of our physicians have told us that right out of their residency or during residency, things can happen, bad things can happen. And if a seasoned nurse comes and helps with that, like an OR nurse, so they're in surgery by themselves at night or whatever. So they're really looking at that dyad and putting a seasoned nurse with a resident or an early career physician, and has some great success. So really padding that experience when they first get them, because you're seeing that those same people leaving within 2 years. And so what else are you doing? But you're listening to them, right? Why are you leaving? Again, bring them to the table and just ask and have that conversation.
Those are great. Because we're starting in rural markets, we're starting in a world where there are no services. There's a service shortage. Like, that's why we're starting the business that we started. And so we are designing exactly around for that, which is an advantage, because we don't have to shift, right? I do think shifting is hard and creativity is challenging. I was having a conversation with someone recently at a dinner about workforce, and it dawned on me in the conversation, the comment was, most of our nurses are women, and with the COVID, they need to take care of their kids, and there was burnout. And I was thinking about how I used to round as a doctor, and I would round first thing in the morning, and then there was this big swell of activity. And so I said, what if you actually, so this is a creative solution, not for the nurses, what if you actually asked the doctors to round 4 hours later so that the women could actually go in and do the flurry of activity when their kids are in school? Does that change what they want? Like, again, there's so the reason I bring that up, I don't know if that's a good idea or not, I don't run that business, but that there's creative ways to think about solutioning at a larger scale than just the individual people that are doing the job.
Amazing. Well, I know we're at time now. So, PM, Lisa, Jenny, thank you so much for, all of your insights and spending time with us today. And to our audience, thank you for joining.
Thank you.
Thank you.
Pleasure.
Everybody.
Thank you to Derek and all of our speakers. Please visit our website at hlth.com to catch up on all Health Go Live webinars. And join us in Las Vegas, November 13th through 16th for Health 2022.